basics of pulmonary pathology, including the respiratory tract, upper airways, and lower airways. This slide demonstrates the difference between the nasopharynx, oropharynx, trachea, as well as the lung parenchyma. Right side being right upper lobe, right middle lobe, and right lower lobe. The left side consisting of the left upper lobe and lingula and the left lower lobe. This next slide demonstrates the left mainstem bronchus, bronchi, bronchioles, diaphragm, pleura, and the lobes. This slide demonstrates our respiratory tree. Realize the difference between the cricoid cartilage, tracheal cartilage rings, the primary bronchus, secondary bronchus, and tertiary bronchi. This slide demonstrates a histological section of the secondary bronchus. Notice that there are columnar epithelial cells as well as mucus cells or goblet cells. Also realize that there is soft tissue including smooth muscle and hyaline cartilage. This next slide demonstrates more of a tertiary bronchus with columnar epithelium as well as alveoli. Notice that there are red blood cells as well as macrophages. Also of note is the arteriole. This next cartoon demonstrates the difference between the conducting zones and respiratory zones. Realize that the conducting zones has mucous lining and allows no gas exchange with the blood. The respiratory zone has thin-walled, simple squamous epithelium, which allows for gas exchange. This slide demonstrates a histological section of the alveolar sac. Notice phagocytes, RBCs, as well as the pneumocytes. This cartoon is a representation of type 1 epithelium, type 2 epithelium, the alveolar space, as well as the interstitial cells and endothelium, the lower tract. Atelectasis. What is the definition of atelectasis? It's basically the collapse of the aerated lung parenchyma. There are multiple kinds of atelectasis. The two that we will review right now is compression atelectasis and resorption atelectasis. Compression atelectasis is pleural cavities that are partially filled or completely filled with fluid, blood, pus, or air. Reabsorption atelectasis results from a complete obstruction of the airway. The clinical significance of atelectasis is that it reduces oxygenation and predisposes the patient to infection. Acute respiratory distress syndrome, or ARDS. This is due to a damage to the alveolar-capillary interface, resulting in leaking of protein-filled, rich fluid into the alveoli. This results in intra-alveolar hyaline membranes that impairs gas exchange. There are multiple causes of acute respiratory distress syndrome. They include sepsis, burns, head injuries, inhalation injuries, pulmonary contusions, pulmonary infections, radiation therapy, transfusion relaxants, or drugs. With acute respiratory distress syndrome, scarring often can occur. The clinical features include dyspnea and tachypnea. With very worsening ARDS, cyanosis and hypoxemia can progress to respiratory failure. On a chest X-ray, diffuse bilateral infiltrates can be seen. Diffuse alveolar damage, or DAD. This is when you have some alveoli that are collapsed. There's dense proteinaceous debris that is in the alveoli, and there's hyaline membranes, as seen by the arrows. With hyaline membrane disease, there's a lack of surfactants. This results in respiratory failure in the newborn patient. The most common cause of death in premature infants is hyaline membrane disease. It is also associated with maternal diabetes, as well as birth by C-section. Surfactants. Surfactant is a substance that is made primarily by lecithin and is secreted by type 2 pneumocytes. Surfactant reduces our surface tension, which allows for expansion and prevents atelectasis. Assessing surfactant level is assessed by the fetal pulmonary maturity ratio, or lecithin-sphingolipid ratio. The pathology for hyaline membrane disease include heavy atelectatic lungs with some dilated alveoli. Also, intra-alveolar hyaline membranes are present. In terms of complications, bronchial pulmonary dysplasia secondary to high concentrations of oxygen can be seen. Patients can also have intraventricular brain hemorrhage, as well as necrotizing enterocolitis. COPD. COPD is a group of disorders that is characterized by airflow obstruction. This can result in a VQ mismatch. Normally with COPD, you have a decreased FEV1 with increased or normal forced vital capacity. Obstructive diseases versus restrictive diseases. Obstructive diseases cause an increase in resistance to airflow due to partial or complete obstruction. The patient has no problem breathing in, but they have a problem with blowing out. Diseases that are obstructive include emphysema, chronic bronchitis, bronchiectasis, and asthma. Restrictive diseases are characterized by reduced expansion of the lung parenchyma with a decreased total lung capacity. These diseases consist of kyphosclerosis, pleural diseases, IPF, or neuromuscular diseases. Emphysema. The definition of emphysema includes an abnormal, permanent enlargement of the air spaces due to terminal bronchial destruction. This is strongly associated with smoking. Clinically, the patient will have an increased anterior-posterior diameter of the chest with increased total lung capacity and hypoxemia. These patients can also have hypercapnia. There are two separate types of emphysema: centrilobular emphysema or pan-acinar emphysema. The centrilobular emphysema is associated with smoking is normally seen in the upper lobes. Pan-acinar emphysema is due to a lack of alpha-1 antitrypsin and is commonly seen in the lower lobes. The pathogenesis of emphysema is due to a misbalance between protease and antiprotease mechanisms. This imbalance is due to smoking or oxidant therapy. In terms of smoking, the smoking attracts and stimulates the release of elastins from the neutrophils. The oxidants from cigarette smoke causes oxygen-free radicals to form, and the neutrophils inhibits an alpha-1 antitrypsin. Hereditary alpha-1 antitrypsin deficiency is found on the pi gene on chromosome 14. The pi Z allele codes for structurally deficient proteins that can accumulate in the liver. The pi ZZ in homozygous states associated with pan-acinar emphysema and early hepatic cirrhosis. In terms of pathology, normally with a patient who has emphysema, you will have large hyperinflated lungs as well as apical blebs or boli. The clinical features include cough, dyspnea, a prolonged expiratory phase, wheezing, and increased mortality. The patients with increased mortality normally have respiratory acidosis and complications from cor pulmonale. The clinical features of emphysema include the classical pink puffer. Patients can overventilate and remain well oxygenated. The blue bloater can have recurrent infections, abundant purulent sputum, as well as hypercapnia. This slide demonstrates a gross slide of emphysematous disease. This slide demonstrates bullous emphysema. You can notice in this picture the bullous emphysema, which are large subpleural blebs. Dilation is also found in distal parts of the acimus. The rupture of the boli can cause spontaneous pneumothoraces. Chronic bronchitis. Chronic bronchitis is a patient who has a persistent cough with sputum production for at least 3 months in the last 2 consecutive years. This is often characterized in the blue boat. They are normally cyanotic and have wheezing. The pathogenesis of chronic bronchitis includes chronic irritation by inhaled substances, especially smoking. Hyperplasia of the submucosal glands cause increased hypersecretion of mucus and increased Reed index. Asthma. Asthma is a chronic relapsing inflammatory disease that is characterized by reversibility of the bronchial constriction. There are several types of asthma. The most common type of asthma is atopic asthma. This is due to environmental antigens. Type 1 hypersensitivity via IgE bound to mast cells causes asthma. There is a release of histamines. This normally begins in childhood. Intrinsic asthma is initiated by diverse non-immune mechanisms which can be caused by aspirin, viral infections, exercise, or temperature changes. Normally, with intrinsic asthma, you're thinking of adults. The pathogenesis of asthma includes a chronic airway inflammation and bronchial hyperresponsiveness. Normally, antigen stimulates the induction of Th2 type T cells. The mast cells will release histamine, which will cause inflammation and bronchial constriction. The clinical features can include an attack which can last for several hours. Patients can have prolonged coughing, shortness of breath, and wheezing on expiration. Status asthmaticus is a severe form of asthma which can lead to respiratory failure and death. This slide demonstrates normal mucosa versus bronchial asthma. Recognize that the mucus is increased with the bronchial asthmatic as well as increased eosinophils. Also of note, the lamina propria is very large with increased macrophages. Also, smooth muscle is increased versus the normal bronchus. Bronchiectasis. This is a chronic necrotizing infection of the bronchus and bronchioles, leading to abnormal dilation of the airways. Predisposing conditions include tumors, foreign bodies, mucus impaction, chronic sinusitis, rarely caused by cartagenars, or cystic fibrosis. The clinical features of bronchiectasis include fever, a persistent cough and foul-smelling sputum, recurrent infections which can lead to lung abscesses. The pathogenesis of bronchiectasis include a vicious cycle of obstruction and infection. Bronchial wall inflammation with weakened and dilated airways is also required for bronchiectasis. The gross pathology of bronchiectasis include dilated airways, most often in the lower lobes. Microscopic pathology shows acute and chronic inflammation with exudates within the walls of the bronchus and bronchioles. This concludes this section.